Okay, hello.
Yeah,
How are
hi,
you?
Dr. Gu.
Yes.
Yeah. How are you
Okay,
doing?
and
Yeah.
okay, thank you for Dr. Oh and Dr. Hong, Dr. Young, and we prepared some very complex and somewhat beautiful case. And my first operator is Dr. Kang, is assistant, is technician Zhang. Okay, Dr. Kang, can you explain the patient history?
Yes. A 65-year-old female was admitted for the evaluation of coronary artery disease. A screening coronary CT angiogram showed multiple calcified plaques at the coronary arteries with severe stenosis at left main bifurcation. Following coronary angiography showed 3 vessel disease and left main disease. The syntax score was 30, and the patient had no significant risk factors. And next, and she performed the PCI at mid-RCA region.
Okay, so and this patient was a 65-year-old male and presented with stable angina and referred to our hospital after checking of a coronary CT scan, and we can find the diffuse calcified region. First of all, this patient already treated 1 month ago right coronary region, just a simple region treat, and so the demonstration target was a left coronary system. Yeah. Okay, look at the baseline coronary angio, and this is the arterial coral view, and we can see the distal left main bifurcation region. You know, some suck ostium was a very acute angle.
We cannot see the left main. Did you see? Now you see the right coronary artery. We are looking the right coronary artery.
Okay.
Can you
please connect the left coronary system? Okay.
Yeah.
Can you see here?
Yeah. Of course, go ahead.
Okay, okay. This is the arterial coral view. Look at the left coronary region, and there was some calcification. The left main, the LCX, there was some severe calcified region, and also we can find the distal left main region. And next. The suck angle was very acute, and we can find the distal left main region, and literally it's 101 or 111. So next. So, and this patient has also some discrete lesion of the mid-LAD region, and so, and the right coronary region was already treated. Mid-LAD region was some discrete region, and also the distal bifurcation region. So this time we're going to focus on the distal bifurcation region. How do we treat this? How do we stenting strategy we're going to plan? Okay, any question until now?
Hi, Dr. Park. The LAD mid lesion looks pretty calcified, so sometimes these lesions that look simple but could be very complicated in terms of getting stent there, getting good expansion. So just be aware of that lesion. And obviously, left main circumflex is relatively complex that need IVUS, interrogation.
Definitely. Yeah, right. Because you are very expert, you point out what is the most complex thing for such patients.
Yes, Alan, can I make a note?
Yeah.
This is Nico Pijls. I would also wonder, can we treat the LAD lesion without touching the diagonal? Can we treat it as a simple LAD, or is it a bifurcation lesion? That's also an important issue.
Yeah, right.
Yes.
So, and this patient is at first there is there was the moderate, severe calcification, mid-LAD distal left main lesion, and at first we're gonna treat the mid-LAD region, and next. So initially we tried to put the IVUS evaluation for mid-LAD region, but very tight. IVUS doesn't pass. So next we did. Compliant balloon dilation using the 2.5 balloon and 15 millimeter, and then next, we can find some dissection of the region, and at this point we check the IVUS, the mid-LAD region. So this is the mid-LAD part, and the distal part was 2.7, 2.6, and then the plaque was located from the lateral part in the 4 o'clock to 9 o'clock. There is a very tight region. Yes. So, and 3.0, and we can hear, and we find the status of the diagonal branch. Okay, 네. 조금만 빨리 돌려주시겠어요? 예. Okay, okay, slowly. Okay, here this is a circumferential calcium. Calcium was black down. You can see the diagonal ostium is okay. And next. So we decided to IBUS measure the regional length was 30, yes. And the distal reference part is 2.7, is the proximal reference part is 3.2, and we already put the giants 32, 2.75 and 32 millimeter, and then the diagonal ostium was okay. And next. And then we did 3.0 and non-compliant balloon. Next, next, and next, next. And then diagonal, the ostium looks okay. So we are now to the totally can focus on the distal membrane bifurcation region. Okay, next.
You know, angiographic appearance, the tightest portion, which have a severe calcium, a little bit hazy. Right. So you have to confirm that that portion should be evaluated at the IBIS, and the stent lumen area is more than about 5.0. So before shifting the left main, yes. You do better to show us the information about the final stent size at the bifurcation area.
Yeah, definitely. You know, in our cath lab, especially for distal main bifurcation region, if you consider a complex bifurcation region, we nearly 100 patient IBUS guided PCI for distal bifurcation region. So, and I'm going to ask some panel opinion about looking at the region. There was some complex distal bifurcation region. Is there any stenting strategy? Can I hear some comment for that?
Any comments, any suggestion? Michael, any thoughts? How would you approach this left main? Yeah.
Well, first of all, I honestly have to say that I will for sure try to get the best result for the LAD lesion. And I'm not so sure whether we need to do a little bit more pot than we have done so far. For the bifurcation of the left main LAD circumflex artery, for me it is a 1-1-1. When I look at the angulation, probably the more difficult one to reach is the circumflex, which also has a more significant lesion there. So my primary goal would be to go for a stenting of the circumflex and then try to do something like a TAP for the proximal LAD. Yes. We haven't seen the IVUS so far of the left main, but I honestly believe that we do see a plaque distribution that goes from the left main to both the LAD as well as the circumflex artery. Therefore, I personally have to say I would attempt for a 2-device strategy from the beginning on.
Would you prepare the lesions with any cutting balloon or scoring balloon for
it depends on what the IVUS is going to tell me. Honestly speaking, when I do as much calcification and distribution of the calcium as we have seen in the LAD, honestly speaking, I would take the rotablator to prepare the lesion very well, followed by non-compliant high-pressure ballooning. If that is not good enough, we can try to improve a little bit by a scoring device, but we should prepare the lesion in both directions as good as possible, because if we don't have then a good opening of the stent afterwards, we have a significant problem, which we probably will not be able to solve, and the risk there of stent thrombosis in the left main because of inadequately opened stents is quite high.
The angiographic appearance is a 2-stent technique is the immediately looks acceptable, but compared to when you think about it is not easy to adapt the 2-stent technique. Some heavy calcium in the circ and some severe angulation. At that time, we need a very strong backup support of guider. But in my eyes, the guider looks like a jerkin, so I'm worried about some a little bit the poor support. And second one is if you have the difficulty to deliver the stent in the circ, in the very severe calcium and some hyperacute angulation, at that time you'd better to switch your treatment strategy, just a simple crossover and maintain the circ with a TIMI3 flow. What I mean is actually in this patient, when I look at the right coronary artery, is quite a larger one. So compared to if you want to fix it totally complete and the complete revascularization is okay, but it is a difficult shift to the treatment strategy.
Yeah, right. Okay, it's good suggestion. Okay, so we check the IVUS from the left main is as the Myung-Gi Hong's comment about is we select the jogging caster as usual, but it's definitely XP or the EBU would be much better patient, but now is some we are difficult to pass some device, and so we now checking the IVUS from the LAD to the left main. Can you see the IVUS?
Yes.
Okay, okay, Ron.
Yeah, Ron.
Okay, and this is the Prox LAD, and then we can find, and the lumen diameter is 4.0 nearly. This is Prox LAD. Okay, plaque was huge. Okay, so this is a very tight area was Prox LAD, and then the suck was coming, and this is a very calcified region of the suck. Okay, and this part was the main shaft and the main ostium is lumen is nearly 4.5 and the 5.0. So with and then next 중간으로 넘어가서. Next. So we evaluated the LAD, and then we tried to evaluate the suck IVUS, but does not pass. And then next we tried the balloon. This is 2.0 but even though this is very small, the wire it does not pass. Just 2.0. And next, and so we are the change of mind, and we did the mid LAD, the anchoring balloon, and then we gonna decide to change the wire for suck is a very strong support wire. This is the insertion of the microcaster, and the next. Okay, so we changed the suck wire with a long support wire, and then we're gonna additional balloon. This is a 2.0 compliant balloon again. If it does not pass, we're gonna do refit anchoring for mid LAD part. Okay. 자, 앵커링을 먼저 할게요. LAD 파트를. This is the 3.0. Okay. 자, okay, go.
Nominal.
6 nominal. Yes. This is 2.0. Okay, deflate. Okay, this is the 2.0. Okay, go. 6, 8.
8.
10. 12. Okay, deflate.
2.2.
This is 2.0.
2. Yeah.
Okay, go. 6, 8, 10.
10.
Okay, deflate. 자, go. 6, 8, 10.
10.
12, 14.
14.
Okay.
Personally, I'd like to recommend to stay the balloon in the circ.
Okay, go.
Because there is some chance of the stent delivery to the circ is not available. So at the time, the balloon angioplasty of circ is the final fate of the circ. So I'd like to recommend that the balloon angioplasty complete more and the long duration.
앵커링을 다시 해봐. Okay, one more anchoring. 자, go. Nominal.
This is a 2.0 balloon, right?
Yeah, this is 2.0 balloon. Okay.
So what kind of balloon this is?
Okay, go.
2.1.
This is a usual compliant balloon. Go. 6, 8, 10,
10,
Maybe slightly bigger.
12, 14. Okay,
14.
deflate.
2.5.
Okay, this is long wire 어떤 건가? 요건가?
네.
Okay, we're gonna again.
If you want to fix the left main bifurcation with two-stand technique, what is your preference?
Go. It's usually we're gonna do frequently the crush technique.
Crushing.
Okay. Yeah, right. Okay. Wow. 자, go. 6, 8, 10.
Honestly, when I
12.
see the behavior of that balloon,
Okay.
that is for me
Okay,
a strict
deflate.
indication for use a rotablator
deflate.
to prep the osteal part there. Because
Okay. 자,
bringing in a
Angio.
stent afterwards there will be extremely
Angio, ready?
difficult. It will be difficult to open it there.
Shoot.
So there you see the lesion
Okay.
preparation is.
Then 2.5 있죠? 1번 줘봐.
There is a napkin ring of distal left main sitting there. So, you know, if you don't want to rotablate into the circus, rotablating to the LAD would also help a lot of the compliance of that rounded corner. So sometimes, you know, rotablating in a circ could be that angle could be a bit of a problem. But I think to release the left main LAD resistance proximally will help the circumflex as well. So think about that. Maybe, you know, ballooning, whether cutting balloon, you really need to, it's really quite tight on IVUS, I think.
Yeah, right. And then so we're gonna do the 2.5, and then we're gonna consider is cutting or scoring balloon. This 2.5, is
Yeah, 2.5.
You know, the poor passage of the balloon to the circ is the bad sign for the stent delivery. So you have to always consider that.
6, 8, 10, 2.5이죠? 와. Okay. Okay, great. Okay, deflate. 자, 롱 블룬이 어떤 거예요?
롱와이 중입니다.
이거?
롱와이
맞죠?
맞습니다.
오케이, 테스트. 오케이. 자, 고. 6, 8.
8,
10,
10,
12,
12,
14.
14,
Okay, deflate.
deflate,
Okay, 6, 8, 10,
10,
12, 14,
12, 14,
16.
16,
Okay, deflate.
deflate.
Is that a 2.5 balloon?
Yeah, right, 2.5 balloon.
Just
Okay,
simple
6, 8, 10.
scoring.
10,
Just a simple compliant. 10, 12, 14, 16.
14, 16.
When we do the two-stand technique, what is the fate is during a long-term follow-up is the recurrence of the side branch osteum is a common one. And when you look at that one, if you deploy just a simple 2.5 stent using a two-stand technique, there is a higher chance of the recurrence and the side branch osteum, particularly in this kind of relatively small size of the circle.
Okay, and then we're gonna do additional balloon for scoring balloon for suck.
So far, the angioplasty result of the circ is reasonable so far. So if you do the more angioplasty in the circ and then do IVUS and get information, actually the vessel size and bigger than the 3.0, maybe just let it alone and cross over the left main is another alternative option.
Yeah, very good suggestion. So, and then after scoring balloon, we're gonna try to IVUS again for suck, to evaluate the suck status.
Expectation is that the scoring balloon is a little bit bulky, is that the passage is not easy in such kind of the angulated lesion. 6, 8.
Is this a cutting balloon, I could presume?
Yeah, this is scoring balloon.
Scoring.
Wow.
Yeah.
This is not easy. 자, 이게 어떤 거야?
Therefore, we have to catch up the what does it mean? So.
Wow, very tight. Okay, deflate. Once again. This is the 2.5. 잠깐 다시 만만치 않은데.
롱와요.
I never felt the cutting balloon for like a napkin ring calcification worked that well because it just doesn't have enough.
I think you see these kind of napkin ring calcifications you cannot cut.
Okay.
I think the one and only way to do it is with a rotor
This
blade.
is 2.5.
I only sort of think after rotor blade, and then you might want to expand it a bit more. The cutting was reasonable, but you have to kind of treat it with.
It allows to have these microfissures.
Anan, you have a question?
Okay, and this point of this is 2.5 does not pass. We're gonna change some strategy. Okay.
I think is some very educational. So he does not pass the balloon. But from this kind of cases, we learn that when you look at this kind of cases, we have to select the very strong backup support, not a jockeying guide.
Right, definitely.
So one of the lessons from this case.
Yeah. And in the left main situation, you don't have a whole lot of option to use guide liner or guide. So Gazilla doesn't really do very much. It's just only another couple millimeters into it. So, so you're gonna IVUS the circumflex or the LED?
Yeah, right. I tried to the suck. 우리가 2.5가 들어갔고. 아까 스코어링 볼륨이 그게 사이즈가 얼마짜리였죠?
2.5.
이거 좀 구별을
롱와이어.
이게 롱와이어 같은 거 이거야? Oh, this is it doesn't work for 안 되겠다.
Not easy.
Yeah, not easy to pass the wire. It's acute angle, and initially there is some misconception about the guiding selection. It's XB or VBU. Dr. Hong mentioned. It's definitely a key concept. And 우리가 2.5를 했죠.
네.
그러면은 2.5 커링 있죠.
네.
한번 다시 커링으로 해봅시다.
Okay, Dr. Bach.
Yes.
Go ahead your procedure. We will move to the another lab.
Okay. Catch up with you later. Yeah.
So,
ready?
Hello, Dr. Tamburino. This is Alan Young, and with us we have Moon Ki Hong and Dr. Ho, and a very esteemed panelists. So maybe you can introduce your team and tell us about your case.
Yeah. So the team, you introduce the team because your name are difficult to be pronounced. So
my name is Pil Hyung Lee, and Dr. Lee, and Dr. Kwon here, and we have Dr. Tamburino here. And the second case will be the 60-year-old female, and she came to our cardiology department because of some effort-related chest pain. Actually, she had experienced some chest pain last year at January and took some beta blockers and calcium channel blockers, but the symptom appeared again in February this year. So we already performed the coronary angiogram, and can we see the previous left and right thing?
Can we see the coronary angiography?
We are seeing the coronary angiogram right now. The
right coronary.
Yeah.
We only took the right today, but we have a left coronary angiogram picture.
Yeah, we see it now on a different screen.
Okay.
Yeah, we see it now.
So you can see the
LAD.
LAD right here.
There is a mild disease in LAD that was questioned by FFR, and the result was 0.8. So it's a borderline lesion. It should be noted that there is no circumflex artery because there is a very evident right dominance, as you will see later on. So we think that the right coronary artery is the most important artery, is the target artery that we're going to seal now, we're going to treat now. Moving to the right coronary artery, if possible, that you see, you are looking at the right coronary artery now. You see there is a diffuse disease in the body of the coronary artery, and there is also some distal disease at the takeoff of the PDA, and in a PLA there is some mild stenosis. So what is the plan? The plan is to do a two-step procedure. So today we're going to fix the body of the right coronary artery, possibly with a BRS, and for this purpose, we performed an OCT that has shown us some unexpected result, I would say.
Right.
So, do you want to comment the the OCT?
Okay, actually the lesion was too long, and we took 2 sessions of OCTs. The first, can you show us the first one? This will be the distal part.
Please show us. Okay.
Okay, do you see the OCT now?
Okay.
Perfect.
So this is a distal part, relative normal segments of the RCA. Please go on to the proximal part.
If you see.
Okay.
Plaque rupture first.
The first one. Okay.
No calcium.
No calcium.
Fibrous tissue. Another plaque rupture. One more.
Okay, another session, the proximal one.
This is the second run because the lesion was too long.
Okay.
MLD.
Narrow there, yeah.
Third plaque rupture.
Right.
Fourth. So there is a disruption of the intima, I would say, along the lesion. So we want to fix this. There is no calcium, as you can see. There is a spot of calcium, but it's external, and there is a lot of fibrous tissue. So we think that due to the caliber of the artery that is below 3.5 millimeters, is 3.2, our aim is to implant 2 scaffolds. The length of the lesion is roughly 50 millimeters. So our plan is to predilate, so to do the PSP, so predilatation with the optimal result, at least less than 30% of residual stenosis, with a non-compliant balloon in this case, 3.0, and then moving for 3.5 by 28 millimeters BRS. Is there any comment from the panel?
What is the size of the guider? 7 French?
The guiding catheter is a 7 French.
Could you show us the information of the OCT? What I mean is the vessel size of the distal RCA, mid portion, and the proximal?
3.2. Can you show? You see.
Lumen size and the vessel size.
Distal portion에 lumen size, vessel size. Okay, this will be the distal portion.
As we did a media to media.
Media to media.
Not the lumen.
Media to media, yes.
The vessel size.
But what we want is in such long scaffolds. Albeit the vessel is very large, so we don't have such
almost 4.4. It means even though we use the 3.5, there is some chance of the acute scaffold malposition.
Yes,
watch out.
You can get to 4 with a 3.5.
Yes.
This is distal or proximal?
Distal one.
The size of the right coronary artery is not small; it's a relatively big one.
Yeah.
Corrado,
let's see proximal.
The proximal one.
Corrado,
if
this
it
is
is
Michael.
more than 4, we go for a DS, obviously.
Corrado, this is Michael. Actually, when we look at the angio, we had the significant feeling that there is a lot of calcium along the whole artery. And if you look carefully at the OCT, you do see there is calcium. The second thing is we saw multiple plaque ruptures with deep cavities, and when you look at to encounter these, you have to be very careful afterwards to really embed the scaffold there deeply to the vessel wall, not to have malapposition there.
Yeah,
so my feeling is this goes here more in the direction of a 4.0 to 4.5 scenario than a 3.5 scenario.
It's 4.2, so it's 4.2, you're right. And so in this case, we need to move to DS, not BRS, because
I would agree with that, honestly.
Yeah, I agree with you. I thought the artery was less than 4. And also, in this case, I would say that the calcium is external. There is not much of calcium close to the lumen of the artery. The BRS would have been good if the caliber was below 4, despite the cavity, and the strategy would have been to bury the scaffold in the artery, at least in the major part of the vessel artery length, which is good for the rapid endothelialization. But due to the fact that the artery is a 4.2, as you just calculated now, media to media, we need to change our strategy, and we need to go for a DES, because it's important to avoid, in this case, although the artery is very large, so the risk of scaffold thrombosis is, by the way, not so high, but is still present. We need to have a good apposition of the scaffold along the anterior segment that we're going to treat. And so ADS is most probably used in this case, is most likely used. And another point in this case is we decided to leave the PDA takeoff and the PLA as well as the left coronary artery, because we want to investigate with possibly with a myocardial scintigraphy if there is any other jeopardized myocardium, in order to do a spot and a single vessel, possibly PCA in the vessel responsible of a potential ischemia. Although I don't think that there is a ischemia, residual ischemia, because the FFR in this right coronary artery was significant, was 0.76, if I'm right.
Yeah, right.
And so I think that by eliminating this ischemic lesion, the patient could be asymptomatic, and so we could defer, in case of a recurrence of symptom, further PCIs.
Corrado, maybe you have the chance, once you've finished the right side with a nice result, to have another FFR on the LAD.
Yeah, on the PDA.
Because probably it can rise higher than 0.80 right now, because some collateral filling from the retrograde side could improve the perfusion of the vascular bed.
Yeah, the problem with the PDA is how to treat the PDA, because there is a discrepancy from the right coronary artery and the PDA, and so it has to be a two-stent technique or a simple drug-eluting balloon. I have some concerns in the optimal strategy, in choosing the optimal strategy, because I don't want to stent the bifurcation of the PDA, and a T, a simple ostial stenting of the PDA could be, with a protection balloon on the right coronary artery, could be another possible technical approach. So putting a deflated balloon on the right coronary artery and a stent on the ostium of the PDA, and then inflating simultaneously the two balloons in order to avoid that there is a protrusion of the stent in the right coronary artery. But we will see later on this one. So I would like to start with a predilatation.
Sure.
In this case, although without BRS we can go with direct stenting in this case, but I do prefer to go with a predilatation in almost all cases. In
3.0?
No, a 3.0 balloon,
okay,
at least. 3 or even 3.5 if you want.
3.5?
Nico, would you think that this is a focal stenting, forget about whether BVS or not, the proximal part, and leave the one in the middle alone, or how would you? Because it's pretty long if you fix the whole thing, right?
Yes, it depends a little bit on the
It's 50
hyperemic back recording in the beginning, but as I understand, no, I could live with the idea to stent the AV branch nicely and then measure an FFR of the RDP afterwards. By the way, I do not believe that there will be much interaction between the FFR of the RCA and the LAD here, because the FFRs were almost in the same range, so I do not expect many collaterals from right to left or vice versa.
The same do I.
3.0.
The same do I, because the FFR on the LAD is borderline, so there is no significant.
In a patient like this, it is a good strategy to start with this vessel first, see how she develops clinically, because the FFR of the LAD was borderline, and if she does fine, you can leave it. If she still has chest pain, you can consider to stent the LAD in the second stage.
Do you have the balloon? Yeah, I agree. I agree. Not necessarily do a toilet, a coronary toilet, so an angiographic revascularization. I would prefer in this case, instead of an anatomical revascularization, a functional revascularization.
This is 3.0 balloon.
It's a 3.0 balloon.
Yep. 20 millimeters.
It's non-compliant.
Non-compliant.
Non-compliant balloon. We're gonna do. Okay, hold the wire. Let's go.
So you decide the common DES or BRS?
No, DS, because it's 4.2. I don't want to harm the patient with under expansion or malapposition, I would say. Because with the BRS, if you go over the predicted maximum diameter, you lose mechanical properties. And so you run the risk of also the disruption of the struts of the scaffold, so creating the basis for the late scaffold thrombosis. So I want to avoid this. So you can run the risk of acute and late scaffold thrombosis by using an overexpanded scaffold. Let's have a test, please. Okay, we want to start from this part, just in the small dilatation post after the stenosis.
10,
let's go with the scene. The balloon expands nicely and regularly. There is a small under expansion in the proximal part of the balloon, 14. But it's minimal. Okay, off. We go through the anterior vessel. Okay. Go.
Number 14, 3.0.
Okay. Scene. Okay, done. Okay, off. So in case of the BRS, in this case, I would have performed the pre-dilatation by checking in two views 14. The expansion of the balloon. This is a suggestion that we give to all the operators, because you can have an eccentric plaque, and although there is the OCT that helps us in this case, we do an angio. Ready? Okay, go. Okay, you see the site of the disruption, there is a dissection. We can go with a stent. With 3.5, even a 4.0. What do you suggest? I would go with a 4.0.
4 is okay.
The bigger is the better.
4 is okay. The bigger the better. We go low pressure, and then we check with the OCT if there is a need of a post-deal.
If the longer length of stent is available for longer stent.
Oh, so we plan to implant 55 millimeters of stent. So I don't know if you have such long stents here.
No.
No, we have up to 40 in Italy. Can you take away the, retrieve it. I hold the wire. So it is important. This is one of the mistakes we did at the beginning in the GHOST EU. So implanting the scaffold and not opposing well the scaffold to the vessel wall, which creates the high rate of scaffold thrombosis in the first 4 weeks after the scaffold was implanted. So we had 1.5% of scaffold thrombosis, I remember very well, which was driven mainly by some centers that didn't know how to appropriately implant the scaffold. After that, we published some rules in Euro interventions, and almost all operators adopted the steps that at the end ended with the PSP technique after the study by Puricell that showed that by a specific protocol of implantation of BRS, the scaffold thrombosis at 1 year is 1% versus 3% or 2.5% at 1 year in non-protocol driven BRS implantation. In this case, we have some factors that has influenced our choice. At the beginning, I thought that the vessel was 3.2, but I was wrong. The media to media is is larger, so it's mandatory non-implanting the scaffold, because going up to 4.3, 4.2 with a scaffold means running a risk of incomplete apposition, disruption of the scaffold, and early and late scaffold thrombosis. So what are we implanting?
This is a 4.038.
is a 4.038 DS. We go distal to proximal. We discussed that also in case of BRS, if it was useful to go proximal to distal or distal to proximal. In this case, we are fine. Let's test, please.
Test.
Okay, I go a little bit back. You can implant here. A little small test, please. Another small test. Okay, a little bit back. Okay, you can implant here.
Okay, yeah.
You go to nominal.
Okay, nominal. 10. Nominal 10.
Okay, increase because it's not fully expanded. I think that the post-dilatation has to be done because there is some under expansion, as you can see, in the proximal part of the DS. So meaning is the point where the artery was narrowed. And I think, okay. A small check, can I have a small, no, not now. Just a minute, deflate, let's deflate the balloon. A small check now. Okay, there is some under expansion in the proximal part, but then we go with the non-compliant 4.5 balloon there. So now the point is, where do you want to land with the next stent? So if it is 30 millimeters, we need at least, you see, without dye, that there is at least 15 millimeters more to be implanted. I would like to go just after the conus artery, if you agree. Can we see the
sure.
That one?
You will cover the diastema of the right coronary artery with a stent.
Sorry, you?
You will cover the diastema of the right coronary artery with a second stent.
No, why?
Okay, I just ask about your opinion.
Actually,
no,
there was
no, I don't want. I want to go where the tip of the catheter ends. I want to go there. But the risk I run is that there is some residual stenosis just after the coronal artery.
I think it's an honest question, Corrado, because the disease is not ending at the proximal part where you intend to set the stent. So honestly, I would try to attempt to go to the ostium to have the full tube reconstructed, and not to induce afterwards a kind of edge stenosis happening on the next run.
So we need to
That's my argument.
So what we do, we can take another 30, and in case of need, we do an overlap, which is allowed, although it's a long overlap, because the length of the stent has to be determined. Which length do you suggest? At least 28, I would say.
I think anything around that is probably right if you go really to the ostium. Your stent balloon was 38, 50. So if you look, well, your attempt would take about half of that, means 20 millimeters. So there's another centimeter proximal to the proximal marker where the guide is. So I would attempt something 26. Like 30.
Yeah, 30 or 28, even 28. Because the ostium is not diseased, and before the sinus artery, coronary sinus artery, there is no disease, as you can see. If you see now, the proximal part of the right coronary artery, the first 5-8 millimeters, seems to be good.
The angiographic appearance is, the disease is distributed some diffusely from the proximal part. When you compare the vessel size and the distal RCA, proximal to bifurcation and the proximal right coronary artery, actually the size of the proximal RCA is smaller than the distal RCA size.
Yeah. You are right, although it could be atherosclerotic phenomenon as well, we don't know. But by the way, we need a 4.5 at this point.
Absolutely.
Or a 4 or 4.5. Can we see the last one?
Okay.
This is a 4.0. No,
if you use a stent, it's a 4.0 is quite enough.
Because you can post-dilate it's the same stent. 4.0 by 28 or 30, the same. We're going to do an overlap. We don't care if we do an overlap because we post-dilate. And the caliber of the artery is very, very large. So we don't care.
4.0.
4.0 or 26 to 30. What you have is
we have a 28.
28, okay. Let's test. Let's try. Okay. So even in large coronary arteries and in the relatively simple lesions to be treated, because this is a simple lesion, technically speaking, there are many points of argumentation. Because frankly speaking, in the daily practice, we don't discuss so much in such arteries, but the live transmission are an useful moment for an interactive discussion and understanding more. So I think that 28 is good. Let's test. So I have to go back a little bit with the guiding catheter. Test again. So now I need to see if I'm overlapped, because I think that we are no die. There is still room. There is still room for retrieving a little bit. Okay, now I advance. The ostium is always tricky. Test. Okay, a little bit ahead. Test again. Okay, we are at the ostium. Do you like this?
Good.
Yeah.
Good. Go. Let's go.
Okay.
Okay.
I think it's even though you fix this lesion with just the drug-eluting stent, is the good another educational cases. Somebody's maybe have some temptation to fix it the BBS, not the drug-eluting stent. But after the OCT examination, we changed our mind. So just look at the angiogram and then the next strategy change. I think is that point of view, some educational, 16. Interesting cases.
So we are post-dilating with the same balloon of the stent, the intermediate part of the stent. So in this case, this is a DS, it's not a BRS. Do you think useful doing a OCT after? Because I think it's not mandatory in this case. So in the real world, I don't do any other investigation.
10, 12.
Okay? So there is some under expansion at the same site where there was before the under expansion in the mid portion. Now we go for the angiography, we check, and we decide what to do.
So, Dr. Tamburino, maybe we'll go to the next room and see how
okay,
Dr.
because
Park
our
is
case is very simple, yes,
so
I agree.
Maybe a picture for us before you...
yeah, a picture. Ready?
Yeah.
Go. Oh, I will stop here.
Looks beautiful.
I will stop here.
Beautiful.
Let's go in another view, contralateral view. As expected, because with the...
그 스토리를 얘기하려면 자, DIR 해서.
Okay, Dr. we are back.
Hi.
Okay, so we have some progression and some. It's at first I apologize. This guiding selection was done by my fellows before I arrived here. Slightly criticized.
Yeah.
And then the movie.
Don't say that. That is your fault.
Right.
Don't blame your fellow.
Yeah, right. Just a little. Yeah. So I quickly changed the XB guiding caster. Some definitely very hard region, and so we quickly safely changed using the long wire is XB changes, and we try to the larger of things is compliant balloon, non-compliant balloon, and then we're gonna try to 2.5 scoring balloon, but it does not pass. So and here is we try to people again. Yeah, here we try to the Boston the guide Giller, but you know, at this point, the 2.5 the non-compliant balloon and also scoring balloon does not pass. So we decide to some change, and at this point, we're gonna do the 2.5, the new one, the compliant balloon, the past, and then next. And then the balloon inflation, and then do the guide Gilla is quickly past that region, and then next. And then we follow the stand. Guide Gilla put the distally and the follow stand. This is the 3.0, yes. 23. The giant stand is very, very luckily is the guide Gilla was a backup support to facilitate the passage of the circle wire, and then next. And then we do crush technique. This is the 3.023 giant stand and the balloon crush. And then the pull back, the high pressure, pull back the high pressure slowly. And here we do this is a 3.5 balloon crush. Yes. And then this is we are decide to the left main stand is we initially measured the 4.028 giant stand, and then this is used for the LAO. The cranial view is the match the left main ostium, and then we're gonna pull back high pressure balloon. And then here is the immediate stanting, and then we do part technique. This is 4.58 millimeter. That was based on the IVUS. We do 4.5 part, and next, and then next, and then the second wire is a choice PT wire was easily passed, and then next. We're gonna do is 2.0 is compliant balloon is to facilitate the final kissing balloon. The balloon passage was make easier, and then we're gonna check we have just a little step is a final kissing balloon, and then the final repart. Okay, here we're gonna check the coronary angio.
Ready?
Okay.
Angiographically, acceptable and excellent.
Okay,
But after the kissing balloon angioplasty, the final key point is the measure that the ostium of the circ with the IVUS.
Okay, great.
The ostium of the circ should be a greater because that is the frequent cause of the recurrence after the crushing technique.
So, and you know, I think I don't believe there would be some considerable difference according to two-stent strategies. Gullo stenting, tap technique, is some crush technique, mini tap, DK crush. It means we definitely we prefer the simple stenting is a provisional stenting, but look at the circuit is very tight, and the occupying myocardium is not easier, not small. Right? So we decide to initially plan to the two-stent strategy. This is a 3.5 non-compliant balloon. 와이어 좀 빠졌다.
Circumflex wire.
Okay, we're gonna do final kissing. This is use the 3.5. Okay. 3.0. This is 3.0, the non-compliant balloon. Is for this case is quickly change. The guiding caster was strong support is XB, and also guide Gilla was you know some of a good point to the past the stand for such some calcified is a complex region. 이거 used one U1인가? 이거 U1 들어가야 될 것 같은데.
쓰리오 하나 가지고.
이거 U1 줘야 돼. 이건 쓴 건 안 돼. Okay, I'm gonna change the U1. 잠깐만. Okay. Okay, we're gonna do the final kissing balloon, and previously we just the final kissing balloon, just leave it alone. We're gonna finish the all stent procedure. So recently I saw the repart technique. It's after kissing balloon dilation, some interventional cardiologists finally do repart. It's some make a, some, we're gonna do the kissing balloon dilation. It's a lemon, chopped lemon ostium like some elliptical shape. At that point, some make some more circumferential the shape is the main interventionalist is mainly involved in the EBC is to do the additional RIFA. I don't believe it's that too much work, but there was just trend. This is a new one. Okay, yes. 됐죠? 자, okay, 가자. Go.
Circumflex.
12.
All stent are giants, right?
Yeah, right. Okay.
16.
18. Okay, deflation. 자, 이거 35, 20.
Is that a 3O non-compliance balloon?
Yeah, 3O non-compliant balloon. Okay, deflate.
Left main is 3 pi pi.
3.5 and the 3.0 for suck. Okay, the matching proximal 좀 맞출게.
So did you have a high pressure on each one? How high did you go to each one of them?
Yeah, it's we're gonna do 20, suck 20.
20. Each one is high pressure.
20.
Yeah, and then deflate. So it's 20.
20, 6.7.
Okay, okay, deflate. Okay, and then we're gonna do. 자, go 13.
13.
13.
Okay, deflate. 자, 조금 빼서. Okay, go 14. 14. 16. Okay, 1, 2, 3. Okay, here we're gonna check the coronary angle.
Technically very excellent, crushing technique, and geographically excellent. But
okay,
we do not know about the IV's finding of the bifurcation lesion.
Ready?
Okay. Shoot. Okay,
excellent.
The angiographically excellent. This is, keep in mind is we have rules based on our Assam Medical Center data. If you're gonna put the two stent, it's a minimal stent area. The circle ostium was 5, and the LAD ostium 6. Polygon of confluence zone was 7. The distal lemma part 8. If you're gonna achieve the dead point, restenosis rate definitely less than 5% during the long-term follow-up. So we're gonna check is how much we achieved that cutoff point.
LAD.
Okay, LAD and suck.
LAD.
Yeah. This is we're gonna check the LAD IBUS.
One of the factors for the optimal two-stent technique, like bifurcation stent, so the completely no existence of the stent strut above the side branch ostium, particularly in the ostium of circ, is the best one. It's one of the key points we have to see that during the IBIS examination from the LAD to the left main.
Okay, I was past the
I was passed for the left main to the LAD, and this is distal part of the prox LAD.
Have we ultrasound the mid LAD stent as well? Remember we were talking about validating that as well, right?
Flush 다시 하시.
Yeah.
Flush, and please show us from the IBIS pullback from the mid-LAD portion, because you deployed the stent at the mid-LAD bifurcation, and there is some hazy appearance in the stented portion.
So we have enough time for that?
But I think he anchored the balloon and fixed that already a few times. So.
Okay. We're gonna check again that point. Is a pullback for distally epicranial. Okay. 자,
I see.
시간 충분한가 우리가?
네.
자, 오케이. 네. Okay, go.
Okay.
That was distal part of the LAD and the diffuse region. Okay, that would be some 2.75 giant, 32 is LAD. Distal edge is okay. And then the stent was we did a 3.0 non-compliant balloon. Yes, the stent was fully expanded.
Here is coming.
Calcium.
Yeah, right. Some calcium. We can
quite
find
reasonable. Quite Roger.
Reasonable.
Yeah, this is some calcium.
Even though the underlying calcium.
Yeah, this is the coming of the diagonal branch. This is the upper part of the LAD.
After the end of the proximal margin of the stent, please pull back of the IVUS catheter to the proximal LAD for saving the time.
Okay, got it. And then we're gonna check over here.
Okay,
and then here. Okay. Just the distal part of the. Okay, go start. This is 4.0. Is fully well forced. There is no edge dissection. And then was fully expanded well.
Larger stent area in the proximal LAD.
Yeah, right, very large.
Excellent.
Very nice.
If you achieve more than 3.0 diameter, that means, the 7 millimeter scale.
Grocery.
Yeah, grocery. This is the ostium of circle. It's wonderful. Yes. It's well forced. This is the shaft of the main.
That was
so
where
we
the
tried
napkin calcification was.
Yeah.
Got broken. Yeah, I can see that.
Yeah, definitely. Yeah.
Like
we're gonna try to fully cover the lemon ostium. It's a stent was definitely covered well. It's a lemon ostium. Okay, great. And then quickly check the circle ostium.
You know, the IVUS, the pullback from the proximal LAD to the left main, actually the number of the stent strut above the circle ostium is nothing. So it's a very optionally and excellent.
Yeah, right.
Technique.
Yeah. Just yeah, definitely. Thank you. I just blame slightly, a little bit. Okay, I'm gonna check the circle. The axis was not good. Okay. 이게 axis가 안 맞는다. Okay, I think it's the.
Don't try that because
I don't try it. Yeah, okay. I'm gonna check the test. Final shot 찍고 끝내면 되겠다. Okay, got it. You're gonna check the final shot. Okay, Angel, ready?
Ready.
Pull shot. Okay, great. And then
excellent.
spider.
If you do the insist to the IVUS examination in the circle, because the stent strut was protruded the left main, it makes some injury to the stent by the guider.
Yeah, I agree with you. Okay, thank you.
Good job.
Here.
Yeah.
Okay, I think the overall the angiographic result was excellent. We have some difficult point, and quickly we changed the XB guiding catheter, and the circle was very acute angle, severe calcification. I tried to several balloon using scoring balloon, compliant balloon, non-compliant balloon. All was failed. At that time, I decided to the Boston, the guided Gilla, and the put the guided Gilla, and then the guided Gilla does not easily pass the acute angle. So the planned part, we do compliant balloon dilation, and then track the guided Gilla, and the guided Gilla was luckily past the sarcosteum, and then to put the stent, we did finally the crush technique. I think this patient is very, very educational point by the Dr. Myung-Ki Hong. There are large of a debating portion. Yeah. Any comment or question?
Dr. Call has some.
I think the end result was excellent. A lot of hard work had to be done. But if I look back, the amount of calcification which was seen at the distal left main at the origin of LAD and in the circumflex, I personally would have preferred to debulk it with a rotablator. Possibly the hard work would have been reduced, and you won't have to use a guide Zilla and other thing, but ultimately success is success. I think it's a very good result.
Would you debulk both vessels, or do you just debulk LAD, left main LAD, or both?
I think circumflex. Basically a circumflex.
So I have the last question for some experienced panel is that looking at the initial view, the circle was a very acute angle, was a very tortuous angle. I have many experience for rotablate such that lesion. Can I hear some comment from the expert panel? Have some large of experience rotablation such that lesion at coronary 전에 거?
No, you have this S-shaped appearance there, and if you gently advance the rotablator at 180,000 or so RPM, usually it tracks down there easily. It takes time. That is the important thing. You need to take several runs in order to bring it down there. But once you manage it there, you will see that all the ballooning that you need to do afterwards is much easier and more complete than what you have achieved here with a lot of mechanical force, with the Godzilla and so on. So that is why probably we older ones here in the panel are much more in favor of the rotablator and not follow a kind of avoidance strategy, but more a favorable strategy in using the rotablator.
Probably with a better backup guiding path.
Yeah. If you look at the spider view, I think the part of the difficulty is that spider view is that the napkin wing occurs before the bifurcation, obviously, and therefore forces it to have for you to go around it, and by going around it is created another sort of a curve that makes it more difficult for you. So I think if you just do left main LAD rotablator with a reasonable burr to get rid of that ring and dilate that, you probably have less of a problem going to the circumflex, because when you do the looking at I didn't see a lot of calcification at the ostium of the circumflex. But again, you can rotablate the circ as well. But
Okay, thank you, Dr. Ba.
Okay, yeah, okay, thank you.
Yeah,
okay, thank you.
Good job.
Appreciate, thank you.
How about move to next room? Okay, it's lecture time. Yeah. It's a feature lecture session. We invited Dr. Alok Takfin from Cardiovascular Pathology Institute in the United States. This afternoon, his topic is the pathologic insight about BRS. Dr. Finn, please.
Great. Thank you very much. These are my disclosures. So this slide gives the landscape of the BRS scaffolds that are currently in development. And you can see the majority of them are quite thick-strutted, 150 micron and above. And you have to ask yourself now, will that be competitive? Will that be clinically useful? You can see the majority of the scaffolds are made of PLA or some form of PLA. Few of them have magnesium. Most of them elute drug, and the scaffold degradation time really varies depending on the scaffold. Let's discuss the life cycle of bioresorbable scaffold. Well, the first phase is the revascularization phase, drug elution to reduce the risk of restenosis, mechanical support to maintain patency. That's what you want initially. The restoration phase, drug elution is complete, mechanical support to maintain patency. And then the resorption phase, polymer exposure complete, scaffold support no longer required, natural vasomotion and positive remodeling enabled. Of course, in order to get to this phase, you've got to get through these two phases. You've got to have a product that has enough safety to get you to this last resorption phase, which for competitive scaffolds now takes 3 years, 4 years, or 5 years. You can see that the landscape of completely bioresorbable scaffolds is given here, and the resorption time is given 12 to 18 months, 24 months. We know BVS absorbed, the best known absorbs in 36 months, probably longer, 36 to 42, if not longer. The molecular weight loss over time can be calculated using GPC analysis, and you can see overall that the limit of measurement, the scaffold drops below the limit of measurement by 36 to 42 months, according to this measurement, and I'll show you some other data suggesting that it may take even longer. So what's assessment for degradation of bioresorbable scaffolds? Measurement time points may need to be modified to better capture critical safety parameters based upon degradation profile. earlier time points, prior to degradation, when BRS is still intact, you need to evaluate 45 time points preclinically. During degradation, a yearly assessment, the last time point, you need to see normal restoration of vascular healing. The critical emphasis should be on the exam during degradation. Degradation itself is associated with inflammation, and this inflammation, it's underappreciated, can induce vessel damage, medial injury, granuloma formation, neoangiogenesis. This may not even be observed until the scaffold is 50% degraded. You need to also assess whether the absence of a rigid scaffold leads to adverse remodeling, edge effects for histology shrinkage is also a problem. You need to evaluate for potential toxicity of degradation products, which may be observed. You know, obviously scaffolds are made of different materials, PLA. Some people are using iron, some people are using magnesium. It really depends. Ultimately, the last time point will also depend on evidence of acceptable healing and stability. This is what the BVS, the absorb, looks like versus Zions V. In the porcine model over time, you see here, BVS starts to degrade noticeably by 30 months, and by 42 months, it's almost absent. Zions, as you can guess, is a metallic scaffold. It's seen stable over time. The promise of BVS, of course, as seen in the porcine model, is that as you go over time, the IEL, the luminary expands, positive remodeling. That's not seen in Zions. You see the luminaries are very stable, and this is really the promise of what BVS can do for you. You can see the inflammation score is very different in a metallic drug-eluting stent versus BVS. The inflammation score tends to peak as the scaffold degrades and then come down, hopefully. Zions has low-grade, very low-grade inflammation throughout. Giant cells are really no different. Fibrin score is really no different because both scaffolds are drug-eluting stents. Discontinuities of scaffolds were even absorbed during implantation in the porcine model. That's a normal porcine model. You have to ask yourself, how often does this occur in humans? You can see the scaffold here is malopposed and misplaced. They're not evenly spaced. This one is joined. How much do we get of this during normal routine implantation? This is an example of a BRS, not an absorb, that went wrong. It shows you what can happen when it absorbs too quickly. When it has a lot of inflammation, you can see all of the inflammation around the struts here. You can see that they've destroyed the media, spilling over into the adventitia here and here and here. This is the kind of medial destruction I'm talking about, which really needs to be evaluated carefully in order to understand whether your BRS is acceptable. This is the representative OCT pictures. You can see, we've seen this many times. As the scaffold starts to degrade, the OCT shows absence of these struts here. You can see that the struts start to fill in by 24 months with proteoglycans, and then collagen comes in by 36 to 42 months, also seen on the OCT. You can see here that you can evaluate this using different ways, different stains. This is really an exhaustive slide, but you can see that under Alsatian blue, polysaccharides start to fill in the struts early, and as time goes by, the struts start to fill in the collagen, and that's seen here. And as well, you can look at PAS for glycogen, which is also filling in the struts slowly. Now, what's interesting is translational electron microscopy can really show you things that you can't see by GPC analysis or normal histology. It's very high resolution, and what you can see here is the polymer start to fill in with proteinaceous material as early as 12 to 24 months, and you can see even out to 42 or 48 months, you still see evidence of polymer-like material seen as much as 48 months in the model, questioning whether the scaffold fully degrades as early as people think it does. In terms of the acute thrombogenicity in the porcine model, we do a shunt model to see how much thrombogenicity each stent has intrinsically. You can see absorb performs very poorly here. We've stained platelets in red. You can see how poorly it performs. It's very thrombogenic, probably because it's a very large scaffold, which causes a lot of hemodynamic shear abnormalities. And endothelialization, despite reports of OCT being equal between Zions and absorb, endothelialization is slow and dysfunctional in absorb. You can compare it here to Synergy competitive or Biomatrix and Synergy. You can see the struts at 28 days are completely uncovered, again showing you the impediment to healing that this scaffold really has. We do know, and we could have predicted perhaps, that in clinical trials, the stent thrombosis rate with absorb is significantly higher than with Zions, and that was shown very nicely in this meta-analysis. And subsequently, absorb 2-year data showed, of course, that there was greater TLF with absorb versus Zions. This was mainly it was thought restricted to smaller vessels. When they did the analysis of vessels greater than 2.25, there was no significant difference. Secondary 3-year follow-up, definite or probable scaffold stent thrombosis was seen 3% versus 0% in Xience, just showing you how well Xience performs compared to absorb. And the question is, we need a scaffold that really performs well in this midterm before it absorbs fully. The AIDA study, which was published in the New England Journal recently, really hammered this point and really confirmed these issues with scaffold thrombosis. You can see in this study the minimal diameter of the scaffold was significantly smaller than that with the Xience stent, making a question about whether there was some recoil occurring in the scaffold. And the rates of definite stent thrombosis were significantly higher with the bioabsorbable scaffold absorbed versus Xience, again confirming earlier clinical results. This is a case of scaffold thrombosis that was reported in the literature at 44 months. You can see the BVS was implanted here. At 44 months, however, you can see in terms of the thrombectomy extraction, the vessels occluded, there are still bits of polymer still evident here, indicating the scaffold really doesn't resorb in most patients fully until after this time point, almost certainly. And really the question I think that's become very relevant is, given the size of the scaffold, you can see that BVS 3.0 relative to the surface area of the vessel, as you get down further into smaller vessels, the surface area of BVS becomes unacceptably high. It takes up 36, 33 in a 2.5, 36 in a 2.25, and 40 in a 2.0 vessel. Look at the difference between Xience and BVS. Very, very different. The surface area taken up by the struts is really large, and that's really one of the major issues occurring. So in summary, the bioabsorbable vascular scaffolds take a long time to degrade, at least 3 years here, I think, but longer, show a unique ability to allow for lumen enlargement in the porcine model, thus distinguishing this device from the metallic stents. I think this is really the promise of BVS. Major issues were identified based on pathological evaluation of BRS on a preclinical level. Bioabsorption of polymeric BRS associated with increased inflammatory response. I think that is a key that needs to be paid attention to. What type of inflammation is this? Acute thrombogenicity is greater than the current BRS, probably because it's just very large scaffold. If we could thin it down, it might be more acceptable. Reendothelialization of stent struts is delayed with current bioabsorbable EES technology when compared to contemporary metallic DES. Again, probably an issue of strut thickness. Patients treated with BVS scaffolds have a higher risk of stent thrombosis. I'm talking about absorb. That has been confirmed in multiple clinical trials now versus those treated with metallic stents, which perform very favorably now. I think it's recommended overall that patients continue DAP for a longer term if they've been given a BVS. I don't think there's any consensus statement on this, but I would say 3 to 4 years, if not longer out. Thank you very much.
Thank you very much, Dr. Finn. We have enough time to some question discussion. Any question or comments from the panelists, the floor?
Look, all the data that we have currently for the BVS is related to the BVS and its duration of absorption, which you clearly showed is much longer than we initially anticipated and thought it should be. Now we have data for the biotonic version with the magnesium, which has a 1-year absorption time. If we have a shorter absorption time, that we then have more inflammatory response in the vessel wall to expect, and that probably correlates a little bit into the luminal dimensions that we are going to measure, which are a little bit less favorable with that device versus the PLLA devices?
Yes, I totally agree with your opinion. If you look at other devices that have shorter degradation times, the problem is that they provoke more inflammation, intense inflammation. That intense inflammation tends to destroy vessel structure. It's very difficult to make a device that absorbs quickly that doesn't provoke this type of inflammation, at least using PLA. So I think it's an issue of, and that's probably one of the reasons why absorb was made to be so long in terms of its degradation. The inflammation is controlled and low over time. The faster you absorb these, the more inflammation, the more you risk destruction.
Is that then, if you allow me, the point that the parameter of QCA-based late lumen loss is probably not the right parameter to judge whether this is a good device or a bad device? You see, if you have something far beyond 0.2 versus something which is just 0.3, probably this is not giving you the perspective of a good long-term outcome.
I totally agree with you. I don't think late loss here is relevant. I think measures of healing are important with the BVS scaffold, but the OCT has been used and misused, and I don't think that OCT is being done as carefully as needs to be done to really trust the results. I mean, I think Trophy 2 is an example in which case BVS was shown to be heal at a faster rate than science. I'd say that's virtually impossible.
What is your personal opinion about implanting BVS stents right now? In my country, it is recommended now to interrupt it. The attraction of the BVS is that at the long term, vasomotion could become normal again. We have still to wait for that. In the beginning, we saw that the stent thrombosis was only initially, and then the curves were equal for a long time. So I'm really a little bit confused by that, and probably you cannot give the answer because we do not have 5 or 10 year follow-up studies, but what do you expect for the future? At what point in time will we see the presumed advantages of BVS?
I do believe in the promise of BVS. I do think that allowing the vessel to naturally adapt rather than caging it will result in better results, but we need to get to that point where we can allow it to enlarge. And I think in the meantime, what we're seeing that the product of the device is not healing well enough. And that lack of healing is a significant mitigator, especially when struts are malopposed or not covered, and then they start to absorb. We don't really know if that's a pro-inflammatory, pro-thrombotic absorption process. I think that's one of the issues that is occurring. If we could really thin the scaffold down, improve the healing, make sure the struts were covered over time till we get to that process where we can allow for vasomotion, I think we'd see a lot of promise. Is it possible mechanically, biochemically to do that? I don't know if it's possible to thin it down that much.
Look, have you got any experience in your lab with the Meris, the Indian stent, which is 100 microns?
We have experience with scaffolds in the lab which are in 100 micron range. And I think they do perform well. The issue is you can't really test the mechanical strength of the scaffold in a normal porcine model, a normal rabbit model. You cannot really tell how it's going to perform. You can still see discontinuities. I showed you that. That will happen, and you can see fracture over time, but it's hard to use those models to predict how the 100 micron will perform in terms of its rigidity in humans.
And if the drug release is longer, like it's 90 days, if it is longer, say 6 months, a year, you think the results will be different in terms of inflammation and other things?
I don't know if the drug release is going to be that relevant here. I think no matter what, the scaffold will provoke inflammation, and the inflammation will come, even if the drug release is prolonged somewhat. I'm not sure that's the answer to solving this issue.
Look, in your animal model, when this absorbed stent has disappeared, do you see the surface of the vessel, meaning is it back to endothelial cells covering very little cells underneath, or is it actually there's a scar level? What do you actually see?
In the porcine model, I showed you that the data looks pretty good. It does heal. I mean, the problem with the porcine model, of course, is that it's very proliferative. Everything heals well in the porcine model, no matter how big it is. It's not predictive of humans. If you look in the rabbit model and you look at the quality of the endothelium, you see coverage. It's not as good as it is in other metallic stents. And you still see areas, I'll show some tomorrow in one of my lectures, you still see areas where there's nothing covering the struts. The struts are bare. Like some of the stent will be covered, but other whole portions of struts are totally absent. Whereas, in a metallic stent, what you'd see is you might see some dysfunctional endothelium, but you'd see everything at least have that surface coverage. And maybe the deployment makes a difference. How well does this oppose to the vessel wall? If you get a bit of malapposition or recoil, does that affect this process of healing?
Okay, thank you, Dr. Kim. Yeah.
Thank you.
I really appreciate the panelists and the audience. Thank you for joining us this afternoon. I'd like to close this session. Thank you.